ICU antimicrobial papers. We're going to look at timing, procalcitonin, stewardship, ESBL, candidemia, extended infusion, MRSA, de-escalation. And the core message is you hit fast and right, stop at 48 to 72 hours with cultures and extended infusion for severe infections, and never Zosyn alone for ESBL. So let's look at the first study, Kumar 2006. This is the famous ICU trial 2731 retrospective study. Each hour of antibiotic delay and septic shock costs about 7% survival. So less than 1 hour, you started the right antibiotics, 80% survival. Greater than 1 to 6 hours, then you're 42% survival by hour 6. So the odds ratio is 1.119 per hour of delay, 5 times higher mortality with inappropriate antibiotic empiric coverage. And then, of course, 25% survival if by 36 hours you haven't started the right antibiotic. Surviving Sepsis Campaign 1 hour bundle was built on this trial. Again, a retrospective multi-center, 2,700 patients in 10 ICUs, blood cultures times 2, antibiotics within an hour of recognition, broad spectrum, reassess at 48 to 72 hours. So just remember that every hour, 7 to 8% decreased survival, and inappropriate coverage is 5 times worse mortality. And that's the foundation of the 1 hour bundle. PRORATA, procalcitonin-guided antibiotic, safe stewardship in the ICU, Lancet 2010. The procalcitonin-guided stopping 23% fewer antibiotic days with no harm. So you had ICU adults on mechanical ventilation with suspected bacterial infection, and procalcitonin-guided stopping, the antibiotic days 14, standard care, this antibiotic-free days was 11.6, and the mortality was the same. And 14.3 versus 11.6 was a positive p-value. 23% reduction in antibiotic exposure, no increase in harm. You should stop antibiotics when the procalcitonin is less than 80% of the peak value or less than 0.5 on consecutive days. It's safe. It had 23% less antibiotic days, identical mortality. And the next study is the MERINO trial by Harris et al., JAMA 2018, looking at Zosyn versus meropenem for ESBL bacteremia. Never you should use Zosyn for definitive ESBL bacteremia. So we looked at E. coli, Klebsiella pneumonia, bacteremia, ESBL 26 centers, meropenem 1 Q8, 30-day mortality was 3.7%. Zosyn was 12.3. So you have a 3 times higher mortality with Zosyn. The DSMB stopped the trial early. Why does it fail despite having in vitro susceptibility? Because at high bacterial inocula, the beta-lactamase production overwhelms pip-tazo activity. In vitro susceptibility does not predict in vivo efficacy. And Rocephin-resistant E. coli, you should use meropenem or ertapenem, no exceptions. Again, why the sensitivity report lies for ESBL is because ESBL producing organisms generate beta-lactamases that overwhelm the pip-tazo at the concentrations achieved at infection sites, even though the organism appears susceptible in the lab, which uses low inocula. So the lab uses 5 times 10 to the 5th colony forming units. Bacteremia may involve 10 to 7th or 8th. Okay, so the study by MERINO et al., JAMA 2018, basically the Zosyn mortality 12.3% versus meropenem 3.7%. And you should use carbapenem, and don't get fooled by the in vitro susceptibility. Riboli and EMPIRICUS candidemia treatment versus empiric antifungal treatment. So you should treat proven candidemia and never treat colonization, the two trials that define the line. Riboli, New England Journal of Medicine 2007, Timsit, JAMA 2016. So they looked at, Riboli looked at candidemia, 245 patients, a fungin versus fluconazole for proven candidemia, and the echinocandin was superior to fluconazole, first line for all ICU candidemia, whereas the Empiricus looked at empiric mycofungin versus placebo in colonized ICU patients, and the mortality was not different at 28 or 90 days. So the line is between treatment and overtreatment. So proven candidemia, positive blood cultures, you should use echinocandin, not fluconazole. That is proven to have a mortality benefit. But if there's colonization, then you do not treat empirically because there's no mortality benefit. So the Candida score can, so that's greater than 3, TPN, surgery, multifocal colonization, severe sepsis can guide preemptive treatment, but still requires clinical judgment. So you should treat proven candidemia with echinocandin and not fluconazole, but do not treat colonization empirically. No mortality benefit, even with multi-site colonization and organ failure. The next study to look at is the Roberts et al. Clinical Infectious Disease 2014. This is beta-lactam. Standard dosing fails critically ill patients. So this is 68 ICUs, 10 European countries, 248 critically ill on beta-lactams. So 50% were at the minimal acceptable MIC target and versus the optimal bactericidal 100% over the MIC target. So the odds ratio of failure to reach 50% led to clinical failure. Every quarter of patients who failed the PK/PD targets experienced measurably worse clinical outcomes. Why the standard dosing fails in the ICU? Because you have augmented renal clearance. That means the drug is cleared faster. You have increased volume of distribution because of third spacing, and you have hypoalbuminemia, so less protein-bound drug reservoir. So it turns out that the beta-lactam killing is time-dependent, and the time above the MIC is what drives the bactericidal effect. So intermittent bolus gives you valleys below the MIC, so a solution would be extended or a continuous infusion. So the 4 PK/PD solutions for critically ill patients. One is extended infusion, meropenem 1 gram over 3 to 4 hours instead of 30 minutes, increasing the dose, doubling in, so you're doubling it, and continuous infusion, which is what we'll see in the BLING III strategy, and therapeutic drug monitoring. So standard dosing fails 25 to 54% of ICU patients. Beta-lactam kills by time above the MIC, not peak, so you fix it. Extended infusion, higher doses, and in augmented renal clearance patients, and continuous infusion in severe infections. So this was the trial that showed that you have achieved only half of the ICU patients are more than half of ICU patients are underdosed, and that's what they shot. They looked at the PK/PD, seeing how many patients with standard dosing actually got greater than 100% MIC target. That's what this looked at, to see if you were actually getting the number you wanted by giving standard dosing. Whoops. The next trial is the BLING III. It's sort of the next step on here. So JAMA 2024, extended infusion, reducing ICU mortality 21.9% versus 25%. So we're looking at continuous meropenem versus intermittent. The 90-day mortality is 21.9% versus 25% when you had intermittent. So you had a significantly better mortality with the continuous infusion. This is for the meta-analysis is also followed in Lancet, showing consistent benefit across the large randomized controlled trial and other trials. The benefit is strongest with higher MIC organisms, severe infections. So how should you prescribe the infusions, the beta-lactam? So the meropenem should be 1 to 2 grams over 3 to 4 hours every 8 hours. Zosyn should be 4.5 grams over 3 to 4 hours every 6 hours. And that should be an extended infusion and not a continuous due to the stability. And cefepime should be 2 grams over 3 to 4 hours every 8 hours. So this BLING III trial with 7132 patients looked at continuous infusion meropenem 90-day mortality and showed a mortality benefit versus intermittent infusion meropenem. That was the standard at that time. So for severe ICU infections. Next trial is the MRSA bacteremia, Fowler, and the IDSA MRSA guidelines in 2020. So for bacteremia, daptomycin equals vancomycin, but never daptomycin for MRSA pneumonia. So when you should use, so this is a multinational randomized controlled trial, 246 patients, daptomycin versus vancomycin. Vancomycin for MRSA pneumonia, MRSA bacteremia without access to daptomycin, MRSA meningitis. And daptomycin should be used for MRSA bacteremia, but never for MRSA pneumonia because the surfactant inactivates it. So that's the takeaway message. Teflaro can be used for MRSA cap bacteremia. Telavancin for MRSA pneumonia, linezolid, MRSA pneumonia alternative. But remember, MRSA bacteremia, dapto equals vanco. And it's, but for MRSA pneumonia, you have vancomycin only. And that's the takeaway. De-escalation evidence then, we have critical care medicine, Leone. We're looking at a meta-analysis, 10 studies, 1,100 patients. So narrowing the antibiotics at 48 to 72 hours or continuing broad spectrum. You actually had an improved mortality with de-escalation. It's beyond just stewardship. Less days in the ICU, 1.5, and no increase in failure, superinfection, treatment failure. So de-escalation is not playing it safe. It's actually, if you don't de-escalate, you're actually exposing patients to harm. This is an older study, Leone Critical Care Medicine, 2014. False sense of security from staying broad because you can cause C. diff, you can select resistant organisms, you could have some drug toxicity, and you could have Candida overgrowth. So de-escalate at 2 to 3 days. Mortality odds ratio is 0.68. So don't hesitate. Staying broad is not safer. It causes resistance, C. diff, toxicity, and candidiasis. Number 9 is the Surviving Sepsis Campaign 2021 and IDSA 2025 Candida. So here is the 2021 antimicrobial bundle, blood cultures times 2 before antibiotics, antibiotics within an hour, broad spectrum, de-escalate, as we saw in the Leone 2014 trial, duration 7 days for most, procalcitonin to guide antibiotic studies, IDSA 2025 Candida. First line is echinocandin, as we went over. And then if it's Candida albicans, you can use fluconazole. Duration greater than 14 days after the last positive blood culture. You should have an eye exam within a week. And basically, this is a review of the most recent guidelines. And then stewardship framework in the IDSA 2016 guidelines. Did I get cultures before starting? Is the bug resistant or susceptible? Because if it's resistant, we know you should be starting a carbapenem. And then Vanco and Dapto based on the site. Am I using the right PK/PD strategy? Severe infection, you should have extended or continuous infusion, as we saw in the DALI and BLING III. Augmented renal clearance, you're going to have a higher dose. If the albumin is low, you're going to have a dose adjustment. Can I narrow it at 48 to 72 hours? And what is my duration? Most sources are 7 days. VAP is 8 days. Candidemia, 14 days from the last positive culture. Endocarditis is 4 to 6 weeks. So again, we went over all these, and you could actually ask these 5 questions at 48 to 72 hours. Cultures before, bug resistant, right PK/PD, can I narrow, what duration? And some of the other trials you should know, we sort of went over this one, the BLING III, vancomycin and augmented and AUC-guided dosing. CHAS-3 was 8 versus 15 days for ventilator-associated pneumonia, which I go over in a different topic. Candida score, looking at TPN surgery, multifocal colonization, and severe sepsis. That is bridging EMPIRICUS and Riboli. So basically, we looked at the Kumar trial, early treatment, improves mortality, PRORATA, when to stop the antibiotics, MERINO, never Zosyn for ESBL bacteremia, treat proven candidemia, not colonization. Standard dosing fails greater than 50% of ICU patients in the DALI study. BLING showed extended infusion. Fowler showed MRSA bacteremia, that Dapto and Vanco are the same. De-escalation meta-analysis. Remember to de-escalate 48 to 72 hours, 7-day duration in the SSC 2021, except for 8 days for ventilator-associated pneumonia. And then the stewardship, 5 questions that you should ask at 48 to 72 hours. Cultures, bug resistance, PK/PD, narrow duration. Thank you for listening.